Okay. Screening is a very crucial part of a family physician, and he should be able to screen different people before this happens. And by means of screening, we here it is important. Here we take it as a malignancy screening, but that screening can also be screened up. You can also screen up the patient about on diabetes, whether the patient has developing diabetes or dyslipidemia or any cardiac abnormality, ischemic heart disease. You can screen. You should be able to screen the patient relevantly. We'll talk about we talk about actually three carcinomas, three malignant conditions which are important. Two from the women's health. One is breast cancer, cervical cancer, and the third is the colorectal cancer. These are the three screening tools that we will discuss here. First, we will do cervical cancer screening. How you do cervical cancer screening?
Pap smear.
Pap smear. Okay, what is the age group? Usually, you do pap smear for these cervical cancers.
Starting from 25 or
20.
20.
Yes. Usually, it starts from 20 to 25 till 40. It's a screening tool for the young women. And okay, we will talk about directly the pap smear. You take the pap smear of the patient and the results comes out. How are you going to interpret that result? Okay, did you guys discuss this in your gyne rotation or no?
Yes, doctor, we discussed it.
Okay, so here we will discuss the things here, and you will go by from the as compared yani based on these guidelines. You can see this in an Oxford GP. If the result is normal, then you place it on a routine recall every 2 years or 3 years. If it is inadequate, if the result says that the sample is inadequate, you repeat it as soon as possible. And after 3 consecutive inadequate results, refer to colposcopy. All right. If the result says that it is borderline or mild dyskaryosis, okay, if there is borderline or mild dyskaryosis, you will check for HPV status. If the HPV status is negative, you will return to 3-year follow-up or 5-year follow-up, okay, depending on the age. If the HPV is positive, then you will refer the patient for colposcopy for further management, okay. So for the borderline or mild dyskaryosis, you check for HPV. If the HPV is again positive, then you refer for colposcopy. Here, if the patient has inadequate, if the result says this is inadequate, then you repeat again, and after 3 consecutive inadequates, you then refer to colposcopy. These two conditions are very clear. Moderate dyskaryosis or severe dyskaryosis, you need to refer the patient for gynos ops to do colposcopy. Here, moderate and severe. For the borderline, you check for HPV, and based on that, you will place your lay your management plan. This is about pap smears. Okay, now if you refer a patient with colposcopy and colposcopy results came out to be negative, then it's okay, normal recall. You will again go to 3-year follow-up or 5-year recall. If it is CIN1, if the treatment says no or yes, or if it is CIN1, it is CIN, then you refer for cytology at 6 months. If there is no CIN1, then 12 months with cytology with colposcopy. If CIN2 and 3, you need to refer it and repeat it, and you need to refer the patient for the treatment. Um, so this is how you're going to interpret the colposcopy results, and this is how you're going to interpret the pap smear results. There are other abnormalities that you can see in the cervical smear. You can have dyskaryotic glandular cells, which refer to the colposcopy. If it is atrophic, usually it is because of the perimenopausal, so no action is required. If there are endometrial cells, it may be normal if IOCD in situ. So if there are endometrial cells, you should ask the patient if the patient has IUCD or not, or hormonal treatment, or if the patient is on first half of the 28th cycle. If there are inflammatory changes, these are also common findings, and it detects that there is some kind of infection going on. You can take chlamydial or endocervical or high vaginal swabs in order to treat that inflammation. You can also see trichomonas, candidiasis. You need to treat that. So this is about the cervical smear. You take the cervical smear, maybe you can get these results or you can get these results, and based on that you will lay down your management plan. So you see here we are talking about here not in a gynecological perspective, but remember that we as a family physician or a primary healthcare physician, we should have a clear cut guideline of if this happens what you are going to do, if this happened what you're going to do, whether is it a referral criteria or you can treat it at your primary health care, or you want to refer the patient for colposcopies. Okay, so this is how you should go about it. We stick to these guidelines on nice guidelines. These are nice guidelines. You can find it in Oxford GP, and don't try to incorporate other guidelines, because the guidelines are different for different guidelines are different from different countries. So for the sake of your standardization, we will follow nice guidelines. Is it the same that you guys read it in your gynae obstetrician, or is it a different thing?
Yes, same.
Same. Good. Now we go to the breast screening. How are you going to screen it for the breast? What is the modality? How you screen it for the breast carcinomas? What test?
Ultrasound or mammogram, depending on the age of the patient.
Good. What is the age? What is the cutoff age for ultrasound?
35,
25. 25?
35,
35.
I think.
Okay, we'll see that. Um, well, first of all, you need to know the referral criteria for the breast diseases. Um, if the patient is having lump, which is with discrete and it is hard, with fixation, it requires referral. If the patient has lump with a past history of breast cancer presenting with a further lump or with suspicious symptoms, you need to refer that patient. However, all the lumps you don't need to refer, right? If the lump has this properties or this history or this nodularity, asymmetrical nodularity that persists after the next period, if applicable, then obviously you need referral for that. Okay. If the patient has lump and his age is 30, greater than 30, with discrete lump with that persists after the next period, so that is a point for referral. You know that you should know that every lump is not going. You're not going to refer every lump of the breast lump. However, you need referral for lump with these categories, with these characteristics, or depending on the age. Is it clear now? You're going to refer these patients with these lumps. Nipple discharge. What are the nipple changes? If the nipple changes are unilateral, eczematous skin that does not respond to the topical treatment, if there is nipple distortion, if there is a spontaneous unilateral bloody nipple discharge, you're going to refer this patient. These are all referral criteria. Okay, we are talking about just referral criteria because physiological nipple discharge, you don't need to treat it, and it's not very it's not a problem. But in primary healthcare, you need to be very vigilant with these danger signs. Here, how are you going to know that whether this nipple discharge is a physiological in nature or a pathological which requires referral? If the nipple discharge is unilateral, single duct, spontaneous, red, brown, black, or profuse when watery, then these are all conditions that this is all pathological. It's not physiological. But if the patient has nipple discharge which is bilateral from the multiple ducts, it present on expression only, green or milky, or stains only, it does not require anything. For the mammogram, for the testing greater than 50, usually you do mammographic screening, um, and you do it after every 3 years to know whether the patient has a mammogram high, any normal mammogram or not. If you want to do mammogram early age, less than 50, if the patient has family history or has a woman known to have a genetic mutation, should be offered annual MRIs. Okay, MRI surveillance is an important thing. For the cutoff for the ultrasound and mammogram, it can be 35 or 40 depending on depends, but usually it depends on the guidelines that you are following. If it's greater than 35, that's okay, but that's not an issue. Here the issue is the normal screening of the of a patient who you want to screen the risk group. The high risk is greater than 50 years of age. You do mammogram. Patient who does not have any risk factor, he should have a mammographic screening at the age of greater than 50. But if the patient has some risk factors attached to it, you need to screen her before that with the MRIs and with the mammogram or ultrasound if it is relevant. So okay, all right, and now we go on to the colorectal carcinoma. All right, now for the colorectal carcinoma, you do screening for the colorectal carcinoma. You will start screening patients with 60 to 74 years of age. You start doing screening for the colorectal cancer, and you do it with fecal occult blood testing. Okay, and every 2 yearly you do these screening tests. This is, I'm talking about patients who does not have any risk factor. If the patient has a risk factor, that means the family history, you need to refer the patient early at the age of 35 or 40. If the patient has these colorectal carcinoma in the first degree, or one first degree with a history of colorectal carcinoma. If the family history is positive, you need to refer the patient for colonoscopy earlier. If not, then you do the colonoscopy FOB. If the FOB is okay, you can do this FOB every 2 years. Now we'll see the result of the FOBs, fecal occult blood. If the FOB result is normal, that means it has 0 positive spots, then you follow this up every 2 years. If it is unclear means 1 to 4 positive spots, you repeat the test. If the second test is abnormal, you go for step up treatment, you go for colonoscopy. If the second test comes out to be normal, first test was unclear, second test was normal, then you perform a third test. If the third test is normal, that means that you have two normals, all right? Second and third, first was unclear. If you have two normal, then you go to the same thing, 2-year follow-up. But if the third test is abnormal, so now you have one abnormal and one unclear, then you step up the treatment and you go for colonoscopy. Okay, so this is for the unclear situations. Abnormal, straight away abnormal, that means 5 to 6 positive spots, you refer for colonoscopy. So normal and abnormal is not a problem. The tricky area is unclear. Same with the pap smear, which is unclear. So what you do in unclear situation, you repeat the test, and whatever comes into that repeated test, then you will step up or step down treatment based on that. So FOB, fecal occult blood, is the first step of screening the patient for colorectal carcinoma. Then you go for the second test for colonoscopy if it comes out to be abnormal. Then you will see what are the interpretations. Colonoscopy. If the colonoscopy is normal, then okay, so for instance here, the patient has abnormal FOB, you refer for colonoscopy. In the colonoscopy, it comes out that there is no abnormality. So you again go for FOB for every 2 years if the patient is less than 70. Greater than 70, by the way, greater than 70 and 75, you don't screen for these tests because there's no longer an effectability of these tests because the mortality in these patients are in any ways are very high. So these invasive procedures are going to harm the patient. So you don't do any screening kind of colorectal screening after the age of 70. So you did a colonoscopy and you find out there are polyps. Then you see that what kind of polyps they are. If it's a low risk polyps, like 1 to 2 small adenomas are present, then you again step down, do FOB. If you have intermediate risk, that is 3 or 4, then you do 3 yearly colonoscopies. If it is high risk, then colonoscopy at 12 months and then 3 yearly. If the colonoscopy result shows cancer straight away, then you need to refer the patient for the cancer screening. Here also, it is very important. It is very clear cut. If the colonoscopy result is normal, okay, fine. If the colonoscopy result has cancerous, okay, fine, you refer it. But what if you have these polyps? Then you need to know what kind of polyps the patient has, and based on that, you will lay down your action plan. This is written that colonoscopy, 50% of the colonoscopies are normal. This is the sensitivity and specificity. And in the colonoscopy, only 10% can be detected for the colorectal carcinoma. So that's about colorectal screening for the colorectal carcinomas, FOBs, and on the basis of what are the interpretation for the FOBs and what are the interpretations uh, for the colonoscopies. This is how you need to know the stepwise approach of the screening tools.
Excuse me, doctor.
Yes.
As a family physician, if an old patient came to me, is it do I